I'm Rich Heller, and this is Surprise Medical Billing and the No Surprises Act. More surprises than you'd think, Part 2. So a brief review. In his State of the Union address, President Biden talked about stopping so-called surprise medical bills, proudly proclaiming that we're already stopping 1 million surprise bills a month. That was due to a piece of legislation called the No Surprises Act, which began in January of 2022. First, and most importantly, the law protects patients. It takes them out of reimbursement disputes between insurance companies and medical organizations like hospitals and physician practices. And to determine the value of the service and the reimbursement level, it went with an arbitration model, which it calls Independent Dispute Resolution, or IDR for short. I know, it's a mouthful. Now, the law itself actually went into pretty explicit detail about how the arbiters should be making their decisions, and it listed out the criteria that they should be using. And it went into pretty granular detail, as you can see here. Now, one of the criteria that they listed was something called the qualifying payment amount, or QPA. As we discussed in Part 1, that's the median in-network rate. That's the insurance company's calculated median in-network rate. Now recall that there were some in Congress that wanted to use the QPA as a benchmark, even though that would benefit the insurance companies. But Congress instead, no, we're going to use an arbitration model. Congress was striving for balance, looking for a process that fairly balanced the concerns of both the insurance companies and the medical providers. And that's why they went with the arbitration model. Now the compromise that was made was that they used an arbitration model, but one of the criteria in arbitration was that median in-network rate. Now, was the medical community thrilled with this? No, because it's not counterbalanced by other criteria and it benefits the insurance companies. But in a compromise, you don't get everything you want. So that's the compromise that was made. The question was, would the administration implement the law in the balanced manner that Congress intended? So what the law actually says is that in determining which offer to select, the arbiter shall consider. And then it lists those various criteria. Now, the way the system works is that after the law is passed, the administration is charged with operationalizing the law through so-called rulemaking. And one of these rules that we were all anxious to see was how would arbitration actually work? So in late September of 2021, the administration issued their rule on how the arbitration would function. And what they said is that the arbiter must begin with the presumption that the QPA is appropriate, and that the arbiter they are required to select the offer closest to that QPA, that median network rate, unless the providers can show otherwise, unless the providers can show why you shouldn't be using that benchmark rate. So let's think about what they did with this rule. With this rule, the administration fundamentally changed the law. They took a law that was rooted in arbitration, and they said, we don't want to do that anymore. We want to use a benchmark law. Now, there was still arbitration, but the role of arbitration fundamentally changed. The way the law was written, the role of arbitration was to determine the appropriate reimbursement amount. But with this rule, they said, no, the role of arbitration is to determine, is the benchmark appropriate, with the presumption that the benchmark, that median network rate, is appropriate. And the burden of proof is on medical organizations, on physicians, to show why the benchmark is not appropriate. In Part 1, I showed this figure. And I asked the question, what would happen if a law was passed that benchmarked off the median in-network rate? Well, we said that practices would get a letter from the insurance companies, and it would say something like this. Dear practice, you got two choices. One, you go out of network, or two, you take a rate reduction. That wouldn't actually happen, though. You wouldn't actually get letters sent to you saying, we're going to kick you out of network if you don't take a rate reduction. That's exactly what happened. It was only a matter of weeks after that rule was issued that the letters started arriving. This one came from Blue Cross Blue Shield of North Carolina, but there were others. And what the letter said, which is exactly what we said it would say, was that, dear practices, you either take a rate reduction or we're kicking you out of network. Now, I want to be really clear. In Part 1, we talked about how the law could be used as a Trojan horse, taking the very real problem of surprise medical billing, but using it to reduce physician reimbursement. This is the smoking gun. This is the proof of that. This has nothing to do with protecting patients from surprise medical bills. Surprise medical billing occurs with out-of-network practices. these letters were sent exclusively to in-network practices, because you can't threaten to kick somebody at a network who's already at a network. So this is the proof that it was never about protecting patients, but always for the insurance companies about reducing reimbursement rates. Now, when I was a child, I loved to watch Saturday morning cartoons, and they used to include Schoolhouse Rock, maybe to try to teach us stuff. And my favorite Schoolhouse Rock was the story of how a bill, named Bill, by the way, becomes law. And it goes through the story of how Bill goes to the House, and Bill goes to the Senate, and Bill goes through committees. And at the end, the president actually signs Bill and makes Bill a law. Now, there was a song. No, I won't sing it for you, but many of you probably remember it. I'm just a bill. Yes, I'm only a bill. And I'm sitting here on Capitol Hill. I wonder if you remember the last verse of that song. And after I become a law, in the rulemaking process, the administration can change me however they see fit. Do you know why you don't remember that verse? You know why that verse doesn't rhyme? Because I wrote it. It's not a thing. You do not get to change a law after it's a law. That's not a thing. And once it's a law, it's a law. You don't get to change it. So what happened when the administration changed the law in rulemaking? Lots of lawsuits. These are only some of the organizations that filed lawsuits as a result of this rule. Now, the first one to file was the Texas Medical Association. And what the judge said in ruling for the Texas Medical Association is that nothing in the act instructs arbiters to weigh any one factor or circumstance more heavily than the others. The act nowhere states that the QPA is the primary or most important factor. Hashtag shaking my head. Now, I added in the hashtag because I was disappointed that the verdict didn't have any hashtags in it. And I felt like SMH was sort of aligning with the sentiment. But again, that was my addition. The other stuff is verbatim from the judge. So this was in February of 2022. So this vacated that part of the rule. And so the administration, and now I'm presuming, read the verdict, read the law, thought about it, thought about how they were going to issue new guidance to align with both the law and what the judge said. Because the judge was really clear. All the criteria equal, the QPA can't be the first or most important. So the administration thought about it, and then 6 months later, in August of 2022, they issued their new rule. And what it said is that the arbiters must consider the QPA and then consider the other information. And furthermore, if you arbiters give any weight to non-QPA additional information, you have to explain in writing why the QPA doesn't already take that information into account. In other words, they read the judge's verdict, they read the law, and they doubled down on the QPA. The QPA comes first again. What? Exactly. So the Texas Medical Association read the new rule, they read the judge's verdict, they reread the law, and they filed a second lawsuit, TMA2. Essentially, second verse, same as the first. The QPA was not intended to be the primary or most important factor in arbitration. And the judge, again ruling with the Texas Medical Association, wrote that the departments have not relinquished their goal of privileging the QPA, tilting arbitrations in favor of insurers. The final rule continues to place the thumb on the scale for the QPA. So the judge vacated this part of the rule. So after the judge vacated that rule, the department issued new guidance, which you can see here. In this guidance, they specified that arbiters, which are called certified IDR entities, again, a mouthful, that those entities must consider the QPA and the other information. The QPA is no longer to be considered first or given any extra weight. Finally, let's hope the arbiters understand this, and that the administration does not again try to favor the QPA. The administration has the right to appeal this decision, and they have filed a notice of appeal as I tape this in April of 2023. But let's hope that the administration does not try to revise this again. So where are we now? Well, the American College of Radiology wrote a letter, and they noted that it's taking medical practices sometimes over 7 months to go through the arbitration process and get paid. And that's because of the huge backlog of cases, among other factors. Now, medical practices are often small businesses, and taking over half a year to get paid for many of them simply isn't sustainable. Recently, Secretary Becerra, the Secretary of Health and Human Services, spoke with and met with Congress. In his meeting with the Senate's Finance Committee, he was asked about implementation of the No Surprises Act by Senator Bennett. And what Senator Bennett, a Democrat from Colorado, who had worked on the issue of surprise medical billing, said is the implementation is a big mess. And he talked about the issues that were plaguing it. The secretary replied that, and I'm quoting now, "I want to say the vast majority, but way, way too many of the submitted disputes are frivolous because there's no cost to file a claim. So everyone is just filing all sorts of claims. That's what is bogging down the system." The secretary did not provide evidence to back up that frivolous claim, nor did the secretary define what makes a frivolous claim. He didn't explain why a provider would want to submit a frivolous claim because the arbitration process is loser pays. So if you go to arbitration, particularly if you go to one with a frivolous claim, and you lose, you have to pay for arbitration. So there's not only no incentive to submit a frivolous claim, there's a pretty strong disincentive to submit a frivolous claim. But let's talk about this no cost to file a claim, because there's lots of myths, and that seems to be one of the myths. This is clearly not true. Not only is there not no cost to file a claim, it's freaking expensive. So in addition to the fees you have to pay to the government for the administration of the process, as well as the fees you got to pay to the arbiter, practices actually have to dedicate resources and time and money to putting together these disputes, putting them together in a thoughtful way, and then submitting them. That is not a free process. And that's in addition to the fees that you actually have to pay to go to arbitration. So the big picture is that delays in the system hurt medical practices because it delays their payment. Medical practices want to be paid in a timely fashion, and then arbitration delays that. Practices want to be in network. If practices are in network, they get paid more reliably, more timely. It's less costly to get paid. So if practices have to go out of network, that's not the preferred option. And if they have to go to arbitration, well, that's the last resort. I would hope the administration recognizes that if there are lots of cases being submitted for arbitration, that's a red flag. That's a sign that the process is not balanced. Speaking of expense, so a little Christmas tale. 'Twas the Friday before Christmas, when no one was looking. CMS thought, let's get something cooking. Not a warning was given. No, it's not an event. We're just increasing your fees, 600%. So here's a tale of two holidays. It was Halloween of 2022, and the administration issued guidance saying that in 2023, the administrative fee to access arbitration would not be changing. It was $50 in 2022, and on Halloween they said it's going to remain $50 in 2023. Now this is important information for medical practices to know as they make their plans. But then, on the Friday before the long holiday weekend for Christmas, it was a 3-day weekend. On that Friday, they said, you know what? We changed our minds. We're going to increase that $50 fee. How much? 10%? 20%? 600%? You're increasing it 600%? Yes. So the Friday before Christmas, they said, starting January 1, the fees are going to increase 600%. Surprise! And by the way, that's only a few business days before the start of the new year. Surprise. So let's do a little bit of math. Let's imagine that you're a physician, a radiologist, and that you typically would be reimbursed for some exam $60. I'm making up these numbers. And instead you get paid $10. So let's go through the math on this. Well, you got to pay a $350 non-refundable administrative fee to the government. You don't get it back if you win. That's simply the fee to go to arbitration. $350. That's the rate they're charging in 2023. Now, separate from that, and in addition to that, you have to pay the arbiter's fee. Now, that ranges between $350 and $1,200. Now, you do get that money back if you win. You do not get it back if you don't win. And you do not get the interest on it. So if the process takes months, your cash is held up in this process, and you're not going to get any interest on it. Now, lots of practices are small businesses. They may not be able to afford to have this much cash if they're submitting lots of disputes held up in this process. Even if they're winning, this impacts their cash flow, and they're losing the interest. This is even more challenging for some specialties. For example, radiology. Most of our claims are for less than $100, and almost all of them are for less than $350. So for us to be able to access arbitration, we have to be able to put many of them together. Using that prior example, it's not worth it to go to arbitration to try to gain $50 if you're going to have to spend $350 even if you win. You'll still be down $300. But what if you could take multiple claims and put them together? Now that's batching. The law not only permits batching, it actually encourages it. But in rulemaking, the batching ability has been severely limited. As a result, practices are submitting a lot more disputes with fewer claims in them. It would be more efficient if we submitted fewer disputes with a lot more claims in them. That would be a more efficient process. But because of batching limitations, we can't really do that. And for radiology, it's even more of an issue because if you can't batch claims together and you can't reach that $350 threshold, you really don't have access to arbitration, do you? I mean, you can go to arbitration if you want. If you want to go for it and spend $350 minimum to try to gain 50, knock yourself out, but it's not cost effective. This is a barrier to arbitration for many physicians. So I think of it as three buckets of problems with the out-of-network process right now. The first one is that access issue. Because of limitations on batching, because of that $350 administrative fee, lots of organizations are not able to access arbitration in a cost-effective manner. Separate from that is the need to have a balanced, fair arbitration process. Now, we didn't really get into the QPA. That's its own talk. Maybe I should do one, but that's its own talk. Problems with the QPA. But here they are in a nutshell. The first one, there's serious concerns about the calculation methodology, which has been specified in rulemaking by the administration. Specifically, the rules allow the insurance companies to ratchet down the rates to non-real world. And furthermore, there's a concern about a lack of integrity of the rates because the insurance companies calculate their own QPAs, and they may do so in a non-transparent fashion. If a medical practice gets a QPA and they think that looks funny or strange, and they want to see the math, insurance company doesn't have to share their math. No, the administration can certainly audit them, but the physician practices, nope, you don't get to look at the QPA. We, the insurance, calculate it, and then we tell you what it is. You don't get to see our math. Now, despite serious concerns about the calculation methodology and the lack of integrity of the QPA, the administration has now twice tried to make the QPA the primary factor that arbiters should be using when making their determinations. And that finally, even if practices can access arbitration, and even if they win a determination in the arbitration process, their reports that the insurance companies are not paying in the appropriate fashion. They're not paying on time, or they're not paying completely. Senator Bennett alluded to this in his comments with Secretary Becerra. So I mentioned the TMA lawsuit previously. So they have filed several lawsuits. So here they are. The first two lawsuits filed by the Texas Medical Association were essentially the same, that the law was never intended to make the QPA the primary or most important factor. That's what TMA 1 said. That's what TMA 2 said. Both of those have been decided both in favor of the Texas Medical Association. Each time the judge said, correct, the QPA was never intended to be the primary or most important factor in arbitration. Arbiters should be considering all of the criteria. The third lawsuit submitted by the TMA regards that QPA, specifically the calculation methodology, and that the QPA calculation methodology results in non-real world economics. And the fourth lawsuit from the Texas Medical Association deals with that barrier to access, that $350 fee, which limits practices from being able to access arbitration the way the law intended. Again, as I'm taping this in April of 2023, the third and fourth lawsuits from the Texas Medical Association are still pending. Now, I want to make sure that for practices that are watching this, that they understand this is relevant to them, whether they are in network or out of network. If you're in network, you run the risk of getting those letters threatening you with rate reductions or kicking you out of network. And then if you're out of network, there's the risk of delayed payment, reduced payment, or potentially even non-payment. Another issue is administrative spending. Administrative spending can account for up to 30% of healthcare spending. We spend more on healthcare spending administratively in this country than other comparable nations, and much of it is wasteful. I hope that we would all agree that the money that practices are spending right now, having to go through all of this arbitration process, would be better invested in clinical care. But even more than administrative waste is the impact on patients. Now, this article is on the economic challenges faced by medical practices focusing on Medicare, which may not always cover the costs of delivering care. Without adequate reimbursement, medical practices cannot sustain patient care services. And as they scale back, especially in rural and underserved areas, patient access to care may be threatened. This is why advocacy is so important. It's important that we make sure that those in Congress, that those in the White House and in the administration understand the concerns, that we, the House of Medicine, are all aligned supporting the intent of the law to protect patients from these so-called surprise medical bills. But the law is not being implemented in a fashion that aligns with congressional intent, and that practices and patients' access to care are being threatened. This is a list of some of the organizations that have been active in advocacy. I also want to include Americans for Fair Healthcare and include a QR code. People can learn more about Americans for Fair Healthcare and consider signing the community statement. Hopefully, in his 2024 State of the Union address, the president can claim that not only is surprise billing improved, but wasteful administrative spending has been reduced, and medical practices and the patients they care for are better protected than ever before. Thank you very much.